Imagine trying to interpret a faint rhythmic scratching sound while riding in a brightly lit 70-mile-per-hour shaking box. For emergency providers, this is the daily reality of auscultation, listening to heart sounds in environments specifically designed to hide them. Misidentifying a murmur here carries an immediate risk. If you administer aggressive vasodilators to a patient with severe aortic stenosis who relies on fluid volume or preload to keep blood moving, their blood pressure can drop to catastrophic levels. Success in these high-stress moments doesn't require perfect pitch. It requires a spatial mental map to organize those fleeting auditory signals into distinct physical locations. This is the Murmur Man, a geometric system designed to organize cardiac data into a single, cohesive mental image. Placing these auditory findings onto a physical body structure anchors the sound to a specific valve, converting raw noise into an anatomical diagnostic plan. The first piece of our map is the head, drawn as a sharp, wide diamond. The right represents aortic stenosis, and the left represents pulmonic stenosis. This shape represents a harsh systolic ejection murmur that swells and fades, a crescendo-decrescendo pattern. On a pacient, these sounds are heard high on the chest. Aortic stenosis is found at the right second intercostal space, often radiating up toward the carotids, while pulmonic stenosis is located on the left. Patients with these narrowed valves often present with a specific triad of symptoms: unexplained fainting or syncope, along with chest pain and signs of congestive heart failure. The diamond head sits at the top to remind you these are sounds of restricted ejection, shooting upward out of the heart during its active squeezing phase, or systole. Below the head, we add the torso. This is a broad, flat rectangle containing mitral regurgitation on the left and tricuspid regurgitation on the right. These represent a uniform holosystolic murmur that maintains an even, plateaued intensity. Mitral regurgitation radiates toward the axilla, while tricuspid regurgitation is at the left lower sternal border. Down the center, a necktie represents mitral valve prolapse. It hangs like a prolapsing leaflet, giving a distinct mid-systolic click. To differentiate between the left and right sides of the torso, have the patient take a deep breath. Right-sided murmurs get louder with inspiration because the physical act of inhaling pulls more blood into the right side of the heart. The torso serves as the central hub for valves that fail to close properly, leaking backward across the entirety of the heart's squeezing phase. Now we add the arms, handling the resting phase. The left arm is a stiff, narrow appendage, representing mitral and tricuspid stenosis. This is the sound of blood struggling through a rigid gate, creating a late diastolic rumble. Catching this rumble requires using the bell of the stethoscope. Conversely, the right arm is drawn pouring back toward the body, representing aortic and pulmonic regurgitation, where blood washes backward, creating a high-pitched, blowing decrescendo. Patients with severe aortic regurgitation show aggressive physical signs. Because blood is constantly falling back into the ventricle, they often have bounding pulses, a very wide pulse pressure, and a head that bobbles with every beat. By hanging these diastolic leaks and rumbles off the sides, the arms isolate resting phase murmurs from the active pumping sounds of the main torso. To finish the figure, we add the feet. Moving the patient into different positions changes the heart's pressure gradients, which can unmask hidden sounds. When patients move into a squat or raise their legs, blood volume surges back to the heart. This increased preload amplifies the sounds of aortic stenosis, mitral regurgitation, and aortic regurgitation. Conversely, when the patient stands up quickly or performs a Valsalva maneuver, they drain blood away from the heart. This emptier, smaller left ventricle makes the click of mitral valve prolapse significantly louder. These posture murmurs prove that auscultation is an active process, using physical movement as an immediate, mechanical bedside stress test. This is the integrated Murmur Man system. When all these geometric pieces are assembled, you have a complete visual roadmap for clinical auscultation. The most critical section for field providers is the bottom left corner, identifying combinations of signs indicating a life-threatening emergency. A murmur in a patient who is in shock indicates a catastrophic structural event, such as a ruptured papillary muscle causing acute mitral regurgitation or a ventricular septal defect following a heart attack. A newly discovered murmur paired with a fever is a primary indicator of infective endocarditis, where an infection is destroying the valves and creating a high risk for septic strokes. Finally, a murmur combined with flash pulmonary edema, the lungs rapidly filling with fluid, is a sign of acute mitral regurgitation, or decompensated mitral stenosis. Environmental noise will always be a factor in emergency care, but with the Murmur-Man mental map, you can bypass the acoustic chaos and identify the precise mechanical failure threatening your patient's life.